Right, so the Calvarial graft, I think the indications for the Calvarial graft, I'm sure all of you all know, but over the years, the use of the Calvarial graft has almost become obsolete. Not many people are using it, courtesy the availability of different options. And the fact that it also resorbs, it is not very robust. But if you have an option, like where you are in a situation where you've already raised the frontal, the coronal flap, and an osteotomy is being made, you can actually use a part of the bone for your grafting. The Calvarium has the outer table and the inner table. And if you take a full thickness graft, you leave a defect. If you just take the outer table, again you leave a defect. It is just palpable. It cannot be seen, but it is just palpable. So if somebody is doing an osteotomy for you, if the neurosurgeon, and please, we are stretching our boundaries to different specialities, but when it comes to taking a bone flap, despite being a properly trained craniofacial surgeon, I don't do a craniotomy myself. So don't go and venture and start taking bone grafts yourself if you're taking the bicortical graft. If you're taking an outer table only, yes, you can do it. But if you're taking a full calvarial block, then you might as well involve your neurosurgeon because they are doing the craniotomy anyway. And then you harvest the inner table from it and you virtually put back the outer table. So I think my talk is almost over. Anyway, so you use the parietal bone for your for your graft. There is some rationale if you almost always use the contralateral side of the dominant side. So if the patient is right-handed, you take the same side. Sorry, you don't take the contralateral side. Just making sure that if at all you have any motor deficits, you don't have it on the dominant side. But it is a very safe graft, so it will not make any difference. So this is a small video which demonstrates the how to take it. If you want to take a block graft of the calvarium, it is very difficult to take it directly. So you can probably start taking a small graft and take that small graft, which allows you to have a small wedge in place, which will allow you to make a graft, to take the graft. And because of paucity of time, I'll just stop the drilling process, take it forward. So what happens is, you see, oh sorry, did I show the window? Yeah. So you have taken a small graft, yeah, you made a monocortical cut. You have the deploy space, which means you're safe, you will not get into the brain, don't worry. And you raise that small graft first. So you can just chisel it out with your periosteal elevator. You see the periosteal elevator is being used, and you just scoop it out. It comes out easily because it's a small graft. But if you want a larger graft, you cannot do that. So that's why when you're doing if you want to harvest a larger piece of bone, you would rather make a small window first, which will allow you to scoop it better. So now you see, now you can take a much larger graft, and it is much safer because you already have the deploy space on one side to wedge it. So you keep doing that. You make your grooves, you make your cuts. Yeah, you've cut a square. You can check the dimension. Almost always try to take slightly more than you need because your dimensions are not almost always accurate. And when you take the bone out and you go back, you're like, oh shit, I should have taken a larger piece. But you might as well try and make a larger piece right in the beginning. So that's it, and you can chisel it, use a curved chisel, get under the deploy space, give a little wedge on all sides. If you try to scoop it from one side, it will crack on the outer cortex. So again, that is another problem. So you need to wedge it. You remember that we made a window before? You see that window? That window is now being used to scoop that bone and make it easier for you to access the outer cortex. And once that is done, you get a small piece of bone, which can be used for probably for your orbital floor injury, or if you want to onlay it somewhere. And you can also scoop the diploid bone. You can also scoop the cancellous bone out for some other grafting purposes. Usually in craniofacial surgery, we have all the panels out. So what we do is we take the inner cortex, and in trauma as well, when the neurosurgeon has done a craniotomy, you can see that, oh sorry, I've gone to the normal mode. You can see that the craniotomy is done, and if you can notice, I need to fill that small gap to make sure that I don't need to have a defect right in the center somewhere. So it's just a small inner cortical bone. You could take much more, as much as you want from the inner cortex, and you don't have any parietal defect or the frontal defect because you're taking the inner cortex. So these are some sensible things that you can do with your bone graft. Again, the use of these calvarial grafts have become very, very obsolete. Not many people are doing it. If you want to reconstruct, say, for a zygoma in a Treacher-Collins syndrome, we take that again. Because we are in that space, we can harvest it, but you are not going to add another incision to harvest this graft. So it's unlikely that we might use it for our day-to-day use. And of course, the fact that we have titanium med-por meshes, we have gel-based meshes which resolve in pediatric practice. I don't see the need for doing this in day-to-day practice. So that's it. Like I said right in the beginning, it's as obsolete as my lungi. Thank you.
Now I'm moving faster. Yes. Do you actually harvest it from the middle of the take it from the lateral sides, right?
Yeah, on the sides.
I'll try to be quite
Never from the center.
fast as possible.
The center is your sacred area. You will never enter with the burr in the center because of the superior sagittal sinus. You don't want to do that. And sometimes it can be slightly thinner in the center. So you are using the parietal bone always. Yeah? And you don't want to use it from the frontal bone again. See, one of the biggest worries of taking this outer cortex alone is the fact that it will be palpable if there is a defect. So you do, and imagine if it is palpable here or visible here, it is not good. So then you take it in the parietal bone, which is well concealed with hair. And if you are anyway in the space where a neurosurgeon is doing a craniotomy, that's what I was advising, take the inner cortex and replace back the outer cortex. You can replace the outer cortex with some PDS sutures as well. So it will be suspended up and that's fine. You can in fact put some plates as well. We can take the questions later once all of this is done. Yeah.